on coordinating addiction treatment in medical settings. And as I promised, my hope is to provide some practical tips for coordinating care across the medical care context continuum. As a reminder, my computer work here. As a reminder, Maryland Addiction Consultation Service, or MACS, is a free service, taxpayer supported here in the state of Maryland, which provides support to primary care and specialty prescribers across the state for the identification and treatment of substance use disorders and chronic pain management. We have, as you know, webinars, educational outreach, and also in-person educational outreach. Also provide phone consultation about both clinical issues and questions about getting people linked to care in the appropriate care context. There is a chat function in this webinar program if you've joined us via computer, and you can feel free to send messages during the presentation. I'm hoping to save some time afterwards as well, so that we can have a discussion if that would be useful. So we have about a week ago, I put this slide together, and at that point we had about half the number of attendees that have now registered for this talk. I was impressed and inspired by the diverse group of potential attendees that had signed up for this. And it just was a reminder to me that integrated care, which is what we're hopefully going to achieve, it really has to, by definition, be team-based care. And it's an opportunity to integrate the strengths from all these different fields that you can see here, from doctors and nurses, physicians assistants, nurse practitioners, community care managers, community health workers, peer specialists, social workers, runs the whole gamut. And it's really important that we hear from everyone who's involved in this, starting with the patient and then with all of us, all the professionals and paraprofessionals. So it also presents some challenge in terms of making a talk, because I'm going to try to present material that will be useful for people regardless of what their professional background is. And if I've glossed over or omitted details that would make kind of the content clearer to you, please do not hesitate to send us a chat or an email. You can email, they would be emailing just you, Anna Whitney, who did this, or using our chat window to try to clarify things. Please don't be shy. Just to let you know a little bit about myself. So I'm a board certified family physician and addiction medicine specialist. I'm currently serving as the medical director of, excuse me, I've just pressed the wrong button, which I'm going to remedy. I'm currently serving as the medical director of the University of Maryland Opioid Treatment Program, which is located at 1001 West Pratt. And we also have some other services on site. So we have an office-based addiction treatment program. Primarily buprenorphine, but we use other medications as well to treat opioid use disorder, alcohol use disorder, and other substance use disorders. We also have an affiliated intensive outpatient program that individuals who are participating in all of our programs can be a part of. And we also have a fairly unique care context there, which is the Deaf Addiction Services at Maryland. It's a program for people who are really doubly disenfranchised, people with who are deaf or hard of hearing, who also have substance use disorders. On site, we also have a health home, which is, as many of you may know, a Medicaid-supported program that helps with medical care coordination for individuals that are participating in behavioral health treatment. On site, we also have integrated hepatitis C treatment and a nascent integrated primary care and infectious disease practice that's kind of growing out of our hepatitis C treatment efforts. That includes some patients that we're managing whose HIV we're now managing on site, as well as providing generalized primary care and acute care services. The goal being to really help people stay healthy and well so that they don't have to continue to use acute care services like the emergency department and the hospital, which, as many of you know, is our patients with substance use disorder tend to have very high utilization of the emergency department and hospitals. And emergency departments and hospitals are good for certain things, but in terms of maintaining people's overall health, we really would like to be able to do this kind of in a lower acuity setting like outpatient practices. We also host some research projects, both biomedical, where we have some drug trials, as well as psychosocial interventions that we hope will support our patients as they recover from their substance use disorders. I should say, by way of disclosure, but I also think it's a strength, I'm a consultant for the Genesis Healthcare Corporation, which is a large chain of nursing homes. Helped launch integrated addiction treatment in one of the skilled nursing facilities here in Baltimore. I've done a little bit of policy consulting and expert witness work for their national corporate organization. It's a small portion of my salary that's supported by them, and they didn't play any role in the formulation of this talk or really any of the work that I've done with Max. So outline for today's talk, I'm going to review a case which will sound probably familiar, review the rationale for this talk briefly. I'm going to talk about what the kinds of treatment settings there are for both medicine and addiction treatment to get a kind of lay the groundwork for what the challenges are in terms of care integration. And then move into a review of challenges that are common across these care continuums. And then I'm going to propose some of the solutions that my Max colleagues and I have encountered kind of as we help participants in Max try to better integrate care for their patients, friends, in their professional context. I'll end with a case that will hopefully be an example of good care coordination, and then leaving some time for discussion, questions, kibitzing, complaints. Word kibitz always reminds me of my mentor, Mike Hayes, who I saw joined us. So hello, Mike. I will say, here's the case. So Jamie is 41 years old and goes to the ER with a spider bite. As we know, patients who say that they have a spider bite most of the time have cellulitis. And Jamie is identified as having cellulitis and is okayed for oral antibiotic treatment. The ER doctor notices some track marks and takes pains to document in the medical record that the patient was identified as an opioid addict, extensively counseled to stop using illegal narcotics. 2 weeks later, Jamie comes back via ambulance after being found down. Labs and imaging are suggestive of endocarditis. Started on IV antibiotics and split dose methadone in the hospital, and the patient's sent to a skilled nursing facility. Once Jamie gets to the skilled nursing facility, the provider in the skilled nursing facility says, hey, there's no good reason for Jamie to be on any methadone because Jamie's not having any pain right now. So the methadone is abruptly tapered and discontinued. Shortly afterwards, Jamie leaves the skilled nursing facility against medical advice, but doesn't want to die. So they follow up in the outpatient infectious disease clinic to get a prescription for an oral antibiotic that would be active against their endocarditis. An enlightened resident physician says, hey, this person has an opioid use disorder, prescribes them Suboxone to treat their opioid use disorder, but shortly after taking it, Jamie develops some chills, nausea, vomiting, diarrhea, and body aches, and fearing impending death, ends up back in the emergency room. So obviously not the best outcome for Jamie. So there's room for improvement, right? There's room for improvement on a couple of fronts. First of all, it can be difficult or impossible for patients to access coordinated addiction treatment in medical settings. And it can be difficult or impossible for patients to access coordinated medical treatment when they're getting addiction treatment. The second point is one that's a little bit out of the scope of today's talk. So I want to really focus on point one, and we'll maybe have another talk on point 2 at some point in the future. And the ultimate goal is really integration. We want to use substance use disorder treatments to facilitate adherence to medical treatments. We want Jamie to stick around in the nursing home long enough to finish their antibiotics. Because if you're dead, you can't really get substance use disorder treatment. We want to use medical settings also to link patients to substance use disorder treatment so that they can continue to benefit from the improved health that they'll hopefully be able to access thanks to their medical care. We want to try to use a harm reduction philosophy to mitigate or decrease the adverse health consequences of their substance use. So acknowledging that people are going to use drugs and trying to use the tools that we have in medical context to minimize the harms from that. And then use coordination of care with other providers to optimize patient safety, particularly with regards to polypharmacy. So I made this graph, which as soon as I made it, I realized that it's kind of challenging to figure out. So we have a bunch of different medical treatment contexts. We have outpatient, we have inpatient, we have post-acute care, which includes home-based care or SNFs. And then in terms of addiction treatment, our system has developed in a way where we have office-based care, we have OTP or methadone program-based care, we have intensive outpatient, which is a psychosocial intervention, we have residential inpatient care. So if we were doing a really awesome job, we would kind of like manage to integrate all of these different addiction and medical treatments together. Truth is, that's a lot of yin yangs. And how many is that? 15. And the truth is, like, there's no reason that we have to divide things in this way if we can kind of rely on some shared principles and understand that given the fractured nature of our healthcare system, we really are just trying to focus on those 4 goals of integration to make sure that people are able to complete their medical treatment whatever the context is, make sure that people are getting connected to substance use disorder care from the medical context, where whatever the patient is going to be able to access, mitigate the harms of ongoing drug use. And the 4th one was also really important, but I can't remember right now. Luckily, I'm not running for office. So just to review a little bit more of the things that were on the chart, for those of you who are not in the addiction world, just to review that there are kind of general ways to divide up the addiction treatments that people receive. You can get peer support through groups like AA, NA, Smart Recovery, Life Ring. There's a few of these, but the most commonly known ones are the 12-step groups. The outpatient treatment and intensive outpatient treatment are primarily focused on relapse prevention, can have some dual diagnosis focus for people with comorbid mental illnesses. Many times they're group focused. The difference between outpatient treatment and intensive outpatient treatment really has to do with the number of hours that people would spend in treatment. The insurance definition is that intensive outpatient treatment means that a person is expected to be present for somewhere between 9 hours at a minimum to up to 20 hours a week, or 19 hours a week in group and individual counseling. In practice, actually, people can show up less than that to intensive outpatient programs. Sometimes they do, but the person has a severe enough substance use disorder that insurance is willing to pay for that level of intervention. Partial hospitalization is more than 20 hours, and similarly, groups and individual counseling that's focused on helping people achieve abstinence or move towards abstinence or sobriety. Contingency management is not an insurance definition, or it doesn't have to do with the number of hours of treatment that people are getting, but refers to the idea that there will be consequences to people's behavior, both positive and negative consequences. Actually, in terms of cocaine cessation, as well as things like adherence to treatment, contingency management has some decent evidence in terms of helping people move towards their own treatment goals. In terms of treatment settings, there's outpatient or home-based care, and which includes a variety of kinds of interventions that I'll talk about a little bit. People also find themselves in inpatient treatment where kind of people have all the services under one roof. And then residential sometimes is a little bit different than inpatient because sometimes people will be living in like a supportive living environment or a sober living environment, and then accessing frequently other services, sometimes IOP level care in an affiliated program, but not on site. We're talking about pharmacotherapies. For opioid use disorder, the evidence is pretty clear and pretty widely adopted. So that there's really 3 FDA approved options for maintenance therapy or medication therapy for opioid use disorder. Those include methadone, which you can get through a opioid treatment program, buprenorphine and naloxone, Suboxone, and other brands of Suboxone, and naltrexone. You can't get a prescription for methadone, but you can get a prescription for the various formulations of buprenorphine and naloxone, including Suboxone, and both oral and injectable naltrexone. For alcohol use disorder, there are some options. There's oral and injectable naltrexone or Vivitrol, Camprel, and Antabuse are also approved for use in people with alcohol use disorder. In terms of every other substance use disorder that you would be trying to treat with medications, there's some sketchy evidence that, and inconclusive at this point, but that other medications could be helpful. I won't say too much about it today, but there are some things that people try for cocaine use disorder or stimulant use disorders, but the jury's kind of still out at how great they are. I'm going to say something specifically about opioid treatment programs, and then talk a little bit about Suboxone as well, because I think that it's useful to know that as you're trying to coordinate care in medical settings. But as many of you probably know, but perhaps not all, opioid treatment programs, or methadone programs, or as they're called in Baltimore, programs, are the only outpatient setting where methadone may legally be used for treatment of opioid use disorder. In a methadone program, the medication, which is usually methadone, but can also be buprenorphine, theoretically naltrexone as well, must be dispensed from the program itself. Medication can never be prescribed from an OTP and picked up somewhere else, like at a pharmacy. Programs are obligated by state law to deliver medication to patients that are already enrolled if those patients go to residential addiction treatment facilities. But programs are not obligated by COMAR to deliver to post-acute settings or homebound patients. Thankfully, in Baltimore, unfortunately, I don't know about the rest of the state. It would be something that Mac's team can look into. But in Baltimore City, the health department actually has a means of subcontracting with one opioid treatment program to deliver methadone to homebound and SNF patients. And that is a system that we use with some success for our patients who have ended up in SNFs. There are a lot of, in general, in opioid treatment programs, there are a lot of rules and restrictions, including restrictions on take-home medication. The expectation is that most people have achieved abstinence from opioids and other drugs, they're expected to come in at least 6 days a week for treatment. Having said that, medical staff may seek exceptions to these restrictions through the OTP extra. And this is really important as we are trying to provide individualized patient-centered care. That yes, there are rules, and the rules are pretty clear about take-homes and self-administration of medication. But we can ask for permission from SAMHSA and from the state to bend these rules. And most of the time, with some basic precautions, we can get this permission. And this is something that Max can help us help you with if you're trying to advocate for your patient and seem to be hitting a wall. In terms of how people are able to access other medications for opioid use disorder, not methadone. So buprenorphine and naltrexone are the other 2 FDA-approved medications for opioid use disorder. Buprenorphine, like methadone, is a long-acting opioid, and it's absorbed quickly, lasts a long time. So that makes it useful for treatment of opioid use disorder. Most formulations have a combination of buprenorphine and naloxone. Naloxone is there to make it less appealing to inject the buprenorphine. Most of the time, it's just along for the ride. And practically speaking, the naloxone doesn't do anything when the medication is used as directed. Here in Baltimore, very few people are injecting buprenorphine naloxone. I've met a couple of people in the last 5 years who do it. And buprenorphine can only be prescribed, I didn't finish the sentence, but it can only be prescribed by an individual who is a physician, nurse practitioner, PA, or I believe a certified nurse midwife who has done the 8 hours of training in the case of doctors and 24 hours of training in the case of everyone else to obtain their Data 2000 waiver through SAMHSA. Now, there's something else that Max can get people connected with if they're not already waived. So that's for the outpatient setting. So either a methadone, an opioid treatment program to get methadone or Suboxone, or really a waivered provider to get buprenorphine formulations. Really, any provider can prescribe naltrexone. This is actually different, though, in medical treatment settings. So for hospitalized patients, there are exceptions. There's no reason to get all tangled up in this. For hospitalized patients, the regulations, federal regulations are clear. So providers may, quote, administer and dispense narcotic drugs, kind of outdated nomenclature, but to maintain or detoxify a person as an incidental adjunct to medical or surgical treatment of conditions other than addiction. In plain language, this means that if your patient is hospitalized for pneumonia, you can put them on any controlled substance you want to help them complete their treatment. So there's nothing magical about methadone. There's nothing magical about buprenorphine. If someone is having opioid withdrawal, you could treat their opioid withdrawal with oxycodone, with Dilaudid, with fentanyl, with tramadol. You can use with methadone, with buprenorphine, anything that a provider is going to use as an adjunct to the medical treatment. There is also an exception in the outpatient setting, and I'll mention this again a little bit later, but there's an exception that says that providers may dispense, again, any narcotic to, I can read it here, it's Title 21 CFR 1306 allows a provider, even one who is not an opioid treatment program, to administer but not to prescribe narcotic drugs to a patient to basically keep them out of withdrawal while arranging for their referral to treatment. The problem is that you can't give more than 1 day at a time. You have to administer it correctly. You can't administer more than 1 day at a time, and you can't do it for more than 3 days total. Beyond that, once you're out of the hospital, you no longer can have this exception that I mentioned here. You no longer have this exception under 21 CFR 1306.07. So if you're in a SNF, you're in a home care, you're in a specialized unit, if you're languishing in the hospital getting treatment, we call them rocks in residency, it's becomes much less clear how people get treatment for their opioid use disorder. Mouse is very sensitive. So as we try to overcome these restrictions to outpatient prescribing, or basically work around them, we meet with a few challenges. The challenges that we encounter include stigma, which probably fuels a lot of these barriers. And then this kind of ends up getting cashed out as structural issues in terms of how our system is set up. We have some personnel and training issues as well. And we can review some of those specifics, and communication issues, basically figuring out how to open the lines of communication to provide this integrated care. So I want to kind of focus on these 4 challenges and mention some of the ways that we've successfully feel like we've managed to address them. But again, there was a good article in earlier in 2019 by Sarah Wakeman and Jody Rich, who argue compellingly that a lot of these challenges, again, can be tracked back to institutionalized stigma. So really focusing on anti-stigma interventions is also important. Stigma, in the words of this Croatian researcher, reduces the value of the persons who have the mental disorder in the eyes of the community and the government. And that I won't read this whole thing, but his point is that medications that are needed in the treatment of mental disorders, including addiction, are considered expensive even when they cost less than other medical interventions for people who are, considered, because they don't have a stigmatized condition, be of greater value to society. So it's important to try to address stigma. So I'm going to mention a few approaches that are important, and it's people who are interested in this subject and who took the time to sign up and even log into a webinar. I think this is a really good opportunity to be the local advocate and local spokesperson in your organization, in your community, to really try to help implement these anti-stigma changes. So the approaches that I would propose are, first of all, to think about the way that you are talking about addiction. This, again, it may seem a step away from the practical tips, but practically speaking, if you can advocate successfully for patients in medical settings by using non-stigmatizing language, then I believe that they will be able to better access the care that they deserve. So examples of using non-stigmatizing language are moving away from the 12-step language of clean and talking about people as abstinent or sober, moving away from the typical stigmatizing language of calling someone who is currently using drugs dirty, or saying that they're having a dirty urine, by saying that they have a positive drug screen, or that they are currently using, rather than saying that someone is a drug abuser. It always makes me laugh because it's not like people are abusing the drug is fine. It's being used. So the person is using drugs. And so it's a person that uses drugs, and currently they're using drugs, but they may not continue to use drugs. Similarly, labeling someone with the name of their disease, not just in substance use disorders, but in general, kind of is recognized as a stigmatizing way of talking about somebody. So we say a person with diabetes, not a diabetic. Say a person with alcohol use disorder, not an alcoholic. And again, calling someone an addict labels them kind of permanently as having this stigmatized condition. So if you say that they have a substance use disorder, it moves us away from that. And it may be that in 10 years from now we'll have different language that we'll be using, but the intent is really the important piece. Intent is to talk about people as people and not as walking disease processes. As I mentioned, harm reduction principles are another way to both get people engaged, and also tends to be a way to battle stigma. Because if we are accepting of patients where they're at in terms of their drug use, then we're more likely to provide them with the full range of care, of treatment options that we are going to offer people who are not currently using drugs. And so if we're thinking about those principles as we're communicating with other care providers and other care coordinators, we just are going to take for granted that licit and illicit drug use, including alcohol use and tobacco use, is just part of this world. And we're going to work to minimize the harmful effects rather than ignoring, condemning, or stigmatizing the people that do use drugs. Harm reduction, again, according to the definitions of the Harm Reduction Coalition, is, again, a practical strategy that tries to help us focus on consequences, again, not on the person who is using drugs. And again, this is fundamentally based on the idea that people who use drugs are just as deserving of respect, support, and care as everyone else. I'm going to shift a little bit, because one of the ways that now 30 years ago was tried to implement as I guess at the time to try to combat stigma, or certainly the way that people talk about it now, is these specific confidentiality restrictions, which apply to alcohol and drug use, actually much more than any other treatment in medicine in America. So, and that is this part of the federal regulations called 42 CFR Part 2. So currently when people talk about 42 CFR Part 2, people talk about the fact that it might help protect people from the stigma of being labeled as someone who uses drugs. We're taking a step back because 42 CFR Part 2, it seems like this incredibly onerous add-on to HIPAA, but it actually predates HIPAA by 20 years or more. It's actually kind of interesting to think about because at the time there was, there were no systematic regulations, as far as I'm aware, on flow of information, of medical information, and there was a concern that law enforcement entities would just go to treatment organizations and say to them, hey, let me know everyone in your treatment organization who's currently using heroin, because that person is clearly involved in illicit use just to get the heroin to begin with. So this probably was a right-headed approach in the 70s when this was implemented to protect people from basically overzealous criminal enforcement of drug use rather than, again, a harm reduction principle. I'm of the opinion that its utility has shifted over time. And I'll just explain a little bit why. It applies to any individual or entity that's federally assisted, so accepts medical assistance or Medicare, and provides alcohol or drug abuse diagnosis, treatment, or referral for treatment, including individuals within larger organizations that don't do that. But if that individual's primary job is to provide drug or alcohol diagnosis, treatment, or referral to treatment, that person is governed under 42 CFR Part 2. Basically, what 42 CFR Part 2 says is that in order to disclose participation in drug and alcohol treatment or progress in drug and alcohol treatment, the patient needs to sign a specific written consent saying to whom that information can be disclosed. The organization has to keep track of who that information is disclosed to. And every piece of information, written information that's disclosed, needs to have this relatively brief but disclaimer on it saying that the information cannot be redisclosed. So if an opioid treatment program discloses to a primary care doctor patients' toxicology screens, that every screen that they send is supposed to have every package of screens the program sends is supposed to have a little disclaimer saying that the primary care doctor needs to protect that information and not redisclose it. Pretty burdensome, and it's actually significantly more burdensome than any other information flow in our medical system. It brings to mind the kind of early days of the HIV epidemic, when my understanding is that similarly testing results, desire for testing, and treatment actually had to meet a higher standard because of concern for stigma. Practically speaking, this is one of the reasons why it's so darn hard to coordinate care, because rather than being able to communicate freely with other care providers, there's just this extra step, which is sometimes impossible to achieve, of getting the patient to sign a piece of paper that says you can coordinate care. So I'm in favor of harmonizing 42 CFR Part 2 with HIPAA in general. Some of my colleagues in the addiction treatment world feel differently, but I think that this is probably perpetuating stigma at this point by marking off addiction, alcohol and drug treatment as somehow special. That's perhaps a talk for another time. I think Dr. Olson also talked about that not too long ago. There's, in addition to the stigma, there are other structural barriers, which include difficulty prescribing and obtaining buprenorphine, as I've mentioned as well already, difficulty obtaining methadone doses in these other sites. So I can review these a little bit. So that's get buprenorphine You either have to have your waiver in the outpatient setting. If you're in the hospital, there needs a formulation of buprenorphine needs to be on site there. And if the patient is in a SNF, the SNF pharmacy needs to have it on formulary, needs to be ready to deliver it. Similarly, as we mentioned, it can be difficult to obtain methadone doses for people that are in SNFs or homebound. One potential workaround is for SNFs to talk to their SNF pharmacies about the 3-day rule. 3-day rule, as I'll remind, was the possibility of dispensing 1 day of medication at a time for treatment for detoxification or maintenance for people who have an opioid use disorder. That could potentially give some wiggle room, although SNF pharmacies currently, in my experience, have not been willing to ever prescribe or dispense opioids for treatment of opioid use disorder, even if it would be compliant under this 3-day rule, 21 CFR 1306. Another way that people have tried to overcome this in Baltimore City is having the health department coordinate this methadone delivery program through a single OTP. Here in Baltimore, it's Glenwood Life. And then OTPs also are responsible for not being particularly responsive. I think that a lot of OTPs here in town, or probably across the country, it's difficult to reach the medical staff. OTPs have strange hours. Sometimes they're open very early in the morning. Sometimes they're open just for a short period of time early in the morning. And so if someone's getting care in another medical setting, it can be hard to learn from the OTP what the OTP provider's recommendations would be. And to get into an OTP, it actually most of the time requires being on site at the OTP, which for a patient with a significant medical problem requiring post-acute treatment, either at home or in a SNF, could really be a significant burden. So as I mentioned, we talked about stigma, we talked about some structural issues, and then communication issues as well. From the substance use disorder treatment side, I think that at the time that a patient establishes care, it really should be an expectation, and the expectation should be very clear that the substance use disorder treatment setting is going to communicate with other medical providers. If through a review of the PDMP, patient is identified as getting a prescription from another, especially for a controlled substance, from another provider, that should definitely be someone that should be communicated with, because controlled substances have the potential for abuse, misuse, diversion, and addiction. And it just should be the expectation that if someone's getting a prescription for regular benzodiazepines, for stimulants, for other opioids, that in order to participate in their opioid use disorder treatment with an agonist medication, the expectation should be that they are willing to have that communication happen. Now, I'm flexible with that. I'll sometimes have the release say, I'll acknowledge that the patient wants to tell their provider first. So I'll say, okay, I won't talk to your provider for a couple of weeks. Sign the thing today, and we can even put on it that this will be effective in 2 weeks, so I can actually talk to them once you've had an opportunity to talk to them as well. There's a concern for significant drug-drug interactions. You're a person who gets 6 milligrams of alprazolam a day, and they want to be on methadone, and the patient refuses to sign consent. This may change the conversation about treatment options for substance use disorders. Not because we're trying to punish anyone, but because we're trying to minimize the harms that patients are going to potentially encounter from both licit and illicit drug use. And if potential problems are identified later in treatment, if someone gets a new prescription, it's okay to, again, make those expectations clear, and if necessary, adjust treatment accordingly for safety's sake, and not for punishing, but for safety, for patient safety. For those of you who are inpatient providers, just revisit this idea that you, as a max attendee, are the thought leader for kind of setting the tone and setting the culture of the inpatient environment. So using non-stigmatizing language, and actually then kind of following that up with some practical approaches. So this thing that we see from time to time, that documenting that the patient has been extensively counseled about their drug use. People who have been hospitalized for a complication of drug use don't generally speaking, need to be told that their drug use has had some negative consequences. The key thing is meeting them where they're at and trying to connect them with follow-up care. And so really that's what the documentation should be focused on, is not saying that the patient, a doctor-focused approach, which is saying, I counsel the patient, but to document where the patient is at in terms of what they're thinking about in terms of their substance use disorder treatment. In terms of getting people connected to SNFs, most hospitals have some kind of clinical nurse liaison, so the SNF staff that's actually detailed to the hospital to facilitate transitions to post-acute care. My opinion, and practically speaking, that if someone is already connected to outpatient substance use disorder treatment, that clinical nurse liaison really needs to loop the substance use disorder treatment clinician in kind of at the time that the patient is potentially going to be discharged to a SNF. This will facilitate medication delivery to the SNF as well as post-discharge transitions to outpatient care. So once the person's getting out of the skilled nursing facility, that their methadone program won't have already discharged them because they didn't show up. They're going to say, well, yeah, this person doesn't need to be on methadone or is going to be getting methadone from somewhere else for the time being, but please do not discharge them from your program because they're coming right back afterwards. Or don't discharge them from your buprenorphine practice because they're going to come right back to you after they've completed their antibiotic treatment at the SNF. So really including, trying to bridge that gap between the inpatient setting and outpatient providers would really be optimal. In the SNF setting, all OTP enrolled patients who are admitted to a SNF should, practically speaking, sign a compliant 42 CFR Part 2 release to allow communication with OTP providers. And the SNF should also, in terms of discharge planning, really connect with medical staff at the local residential treatment facilities to facilitate warm handoffs. We've seen many patients who have really been struggling with their addiction. They get medically stabilized, transferred to a SNF for IV antibiotics or physical therapy, or continued on either buprenorphine or methadone while they're there. And then they say, perhaps they're homeless, perhaps their addiction has been out of control. They say, I really want to go inpatient, and for inpatient or residential substance use disorder treatment, and they hit a wall there. And practically speaking, we can actually try to overcome some of those barriers by doing a couple of things. First of all, setting up a relationship with residential or inpatient addiction treatment facilities ahead of time. Documenting that they're still at very high risk for relapse, even if they haven't currently used when they're in a controlled environment. I've heard stories that residential addiction treatment says, well, this person's doesn't have a severe addiction right now. They haven't used in 3 weeks, but the reason they haven't used in 3 weeks is that they're at a SNF. So really what the criteria is not whether they have used recently, but whether they are at risk for continued use. The other barrier that we've encountered is that residential or inpatient addiction treatment facilities say, well, this person is incredibly ill. They have a wound that requires IV antibiotics. We can't accept this person. But that actually comes from the fact that sometimes when SNFs are trying to get people connected to care, what they're sending along is not an updated progress note, but their admission H&P. So it tends to overstate the acuity of the patient's medical illness, as opposed to saying, hey, this is really good news. The person is really healed from a medical perspective. They're ready to be taking care of their medical issues independently and would be able to participate in full-time addiction treatment in a residential setting. So sending an updated progress note is important, and documenting that there is a high risk for continued use, even if the patient is abstinent at that point in time. Moving to the outpatient setting, again, remembering language that you're a thought leader and that the way that you talk about patients actually affects the care that they receive. And just kind of remembering and reviewing and revisiting and really implementing the principles of motivational interviewing, which is non-judgmental inquiry and a collaborative model of care with your patient. You're trying to figure out over time where your patient is at in terms of their motivation for treatment and their desire to get connected with substance use disorder treatment. I will just mention that if you are an outpatient primary care doctor and you have a patient who you don't think is stable in their addiction treatment at that moment in time, and you don't feel comfortable because of the way that your office is set up, or because of your level of experience, you don't feel comfortable in managing their substance use disorder at that time, I would highly recommend reaching out to a local addiction treatment provider. Max can help you find the one that's going to be convenient for you, to try to kind of establish a consultant and home-based relationship, or a hub and spoke model, where the person would get stabilized at the hub, just like a person with decompensated heart failure would get referred to a cardiologist to get tuned up and then could return to primary care. Similarly, someone with out of control substance use disorder could be referred to a substance use disorder specialist, and then come back to you once they've been stabilized, or once you feel comfortable taking over their care again. And stability has to do as much with the outpatient provider's comfort taking care of substance use disorder, a given degree of substance use disorder, as it does with some external definition of whether someone is stable. So just really important to be able to communicate in both directions between the outpatient setting and substance use disorder treatment setting, just to really understand where that patient is at, and be able to meet them in that place. Again, across all of these settings, oftentimes integrating substance use disorder treatment will represent a culture shift. In the SNF setting, a lot of these places were taking care of people that were specialized in taking care of people who were in geriatric patients, or who had suffered a stroke and needed a lot of one-on-one care. The behavioral issues are not necessarily something that people felt totally comfortable with. So as the local champion, it's important to remind people that the goals of integration are to facilitate adherence to medical treatments. And it's easier to get people to stick with their medical treatment if their substance use disorder is being treated. To try to link people to substance use disorder care, to apply a harm reduction approach, and to really optimize patient safety. Normalizing toxicology testing, having urine toxicology screens just be part of the routine in your practice. That is a little bit of a culture shift, both in the outpatient and post-acute setting. Rather than it being this special thing that you trot out when you are really worried about someone, it's really the idea that if someone has a substance use disorder, toxicology testing really should be kind of a standard intervention. If not at every visit, then at least every other visit, or once a month or something. Stretch it out for someone who's very stable in treatment, but this is kind of like taking someone's blood pressure if you're treating them for hypertension. Checking their urine to monitor their disease stability. Just a normal part of treatment. And again, I think probably everyone who's attending this understands this, but articulating that, understanding that not everyone in a medical setting understands that toxicology testing is just a routine part of care, is that it's useful to kind of repeat that until people start to integrate their understanding. Also important to train people to recognize and respond to opioid overdose, having Narcan around if you're going to be taking care of patients with opioid use disorder, but also not falling into the trap of thinking that every person with a substance use disorder who is altered is intoxicated at that time. That's obviously would be an important cognitive bias to try to avoid. I'm going to mention a couple of clinical issues, and then hopefully leave some time for questions before the hour is up. But from a pain management perspective, probably splitting the dose of both buprenorphine and methadone can help with pain. And not being afraid to use higher dose buprenorphine, or adding on short-acting opioid analgesics for pain in people that are on buprenorphine. The priority should be non-opioid approaches, but interestingly enough, although We hear people say over and over again, buprenorphine is a partial agonist. We hear this over and over again in the Data 2000 waiver training. The truth is, there's no evidence that there is a clinically meaningful ceiling effect for analgesia for buprenorphine. The patient is continuing to have pain and acute pain, short-term pain, and they're already on buprenorphine. It's very reasonable to increase the dose of buprenorphine. It also is okay to add for short periods of time, post-surgical or post-injury, short-acting opioid analgesics. The point is that we're trying to meet the person where they're at. If they're having pain from their broken femur, it's reasonable for them to be on some Percocet in addition to their buprenorphine. The risk-benefit calculus of opioid analgesics is different than for patients without a history of opioid use disorder, and it can be challenging sometimes to coordinate with OTPs to get them to provide split dose methadone. But having existing, actually, if the OTPs are providing, make their medical staff accessible, and you take the time to get the 42 CFR Part 2 compliant release and give the medical director at the OTP a call, my hope is that you'll find yourself actually providing some better, more integrated care. Other clinical issues that come up are patients not acting in a polite and normal way. So just kind of casting these as normal routine parts of medical treatment in patients with substance use disorders can be helpful. So practically speaking, in a SNF is an inpatient training nursing staff to ensure that patients are actually taking their medication, not cheeking them or spitting them out. Trying to mitigate the risks of illicit drug markets, and we'll talk a little bit more about this. Someone is having a specific problem in their facility. And also ensuring that patients haven't kept taking their methadone or their home buprenorphine while they're hospitalized. This ends up being a clinical issue that can lead to some significant uncertainty. And so it's worth actually inquiring. If a patient has methadone take-homes and they're hospitalized. As an inpatient provider, it's useful to say to your patient, hey, where is your methadone? Where are your methadone take-homes? Because your OTP is going to expect that you're going to bring those back. And of course, here in the hospital, we can give you your methadone. Similarly for buprenorphine, hey, we're going to expect that you are going to save that buprenorphine for when you're discharged, that you're not going to take it while you're here. Or alternatively, if it's easier in your SNF or hospital setting for the patient to take their home supply, that you document that clearly in the documentation so that the substance use disorder provider can actually see that that's the case. Specific to the outpatient setting, having the nurses be central to buprenorphine management and methadone management is very helpful. You can try to address aberrant behaviors with pack counts, observed dosing, callbacks, frequent visits, and again, care coordination. I'm going to just briefly say that people worry about not having their patients be able to access counseling at every stage of their medical treatment, but I'm happy to say, just in brief, that this has been studied pretty well, and actually patients who are on waiting lists or waiting to start counseling but get started on their buprenorphine or methadone seem to do just fine. So in the case of opioid use disorder treatment, don't let a lack of access to counseling prevent you from starting or continuing buprenorphine or methadone for your patients. Know that you can use resources like MACS, like STRTA, PCSSO, which provides other webinars, and there's a national clinician consultation center through UCSF. We should all advocate, I think, for abolishing the Data 2000 waiver, which is a barrier to prescribing. But know that we're here to help answer questions, and there are other resources available. So because it's 12:57, I'm actually going to skip this last case. I think the slides will be available, but I will say that everything goes great in this case. And I wanted to leave a couple of minutes for comments, questions, concerns. technical issues. Are we able to allow people to talk? Everyone's muted, it looks like right now. What's that? Just via chat. Okay, got it. Okay. I'm not seeing any chats here, but I greatly appreciate your signing up, and wish everyone happy holiday season. If there are questions, please feel free to contact us via this telephone number on the screen. You can also contact Tracy Summer here at Max as well with additional questions. How many primary care practices, I'm seeing a question before I wrap up, how many primary care practices are completing the 42 CFR Part 2 agreement? So it's an interesting question. Thank you for sending it along. So primary care practices should not have to complete a 42 CFR Part 2 agreement. The 42 CFR Part 2 agreement is really just going to be to get information from a substance use disorder treatment facility to a primary care practice. Nothing says that a primary care provider can't nothing says that a primary care provider can't talk about addiction treatment or provide addiction treatment in their office. And if they provide addiction treatment in their office, as long as most of what they're doing is primary care, and that they're not holding themselves out as primarily an addiction treatment facility, they are actually not governed under these rules. So if you prescribe buprenorphine, if you prescribe buprenorphine for treatment of opioid use disorder or naltrexone for treatment of alcohol use disorder in your office, you do not have to have the patient sign this special agreement. For the person that sent that in, if that doesn't answer your question, please send this along as well. I'm also seeing another question here from a nurse practitioner who provides some treatment options, addiction treatment options as well, and just wanted a little bit more feedback on the services that are available. So we can provide services, consultation services. So we're faculty here at University of Maryland and also from Hopkins. We can answer specific patient questions. We can also answer questions about community resources, and we can answer general clinical questions as well. We've answered questions as granular as what dose of buprenorphine should I put this person on, to questions kind of as global as like, what can I do in my community to help try to address overdose risk? So if there's really any question that you have about addiction, please feel free to call the consult service, and we can try to point you in the right direction, even if we don't have the answer. Thank you very much. I think we can wrap up. And again, thank you so much for your time and attendance, and looking forward to seeing you for our next Max webinar.